Good morning, everybody. It's a pleasure to me being here today, and I am going to give this movement disorder presentation. I chose to go over some specific movement disorder issues that sometimes we see in clinic. I was told to come up with specific things from my specialty that would be a good idea to go over, do a little bit more of explanation, and hopefully I can show this with some cases that I have for you today. So let's start. So I have a case number one. This is a case of left leg tremor. So this is a 68-year-old right-handed female with tremor of her left leg that started after left peroneal tendon repair in September of 2020. She notices that the tremor when driving, and she pushes her leg down onto the floor to stop this uncomfortable movement. She also notices a tightening sensation that goes from her knee laterally down the leg to her foot. She mentions that at times she's also noticed a tendency of this foot to turn inwards. She's also expressed some pain and soreness in that area, and definitely over this period of time of a few months, it's definitely becoming more noticeable. So she's not aware of any triggers except perhaps the position while driving. She notices some alleviating factors that include plantar flexion of the foot, and she's also tried some Ativan and Tramadol that has been prescribed by the local neurologist with some transient relief of those symptoms. Currently, she doesn't have any remission of those symptoms, and is really interfering with some of her walking abilities, especially when walking on uneven surfaces. And for the past few months, she's experienced a couple falls. Not sure whether related to the foot twisting or just mechanical falls, but they did happen as to where before she didn't have any falls. Also, she denied any exposure to any type of antipsychotics or antiemetic medications. So the review of systems was pretty much negative, and mentioned some of the pertinent negatives, but also there we picked up that there might be a little bit of issues with dexterity with the hands, and maybe when playing with the grandchildren, having some difficulties getting up from a low chair. Nothing else that she has identified. Does mention poor sense of smell for the past 10 years. And she does not know if there is any issues with sleep, mainly dream enactment, since she doesn't have a sleep partner. So family history was unremarkable, no mention of Parkinsonism, tremor, or any similar involuntary movements in the family. Social history, she's a retired nurse, therefore she was very in tune with all these bodily movements, and rightfully she was concerned as to why is my left foot turning and tremoring without any reason. She did have the concern, or the only triggering factor for her was this tendon repair that had happened just before the onset of the symptoms. She came with a pre-evaluation MRI that the local neurologist had obtained, which was unremarkable. We didn't have the images provided to us, but the report was pretty much unremarkable. On the initial examination, there was a little bit of a resting tremor on the left upper extremity and mild on the left lower extremity. There was a re-emergent tremor in the left hand, especially when distracted, and just a little bit of bradykinesia in the left hand, very minimal, just maybe slightly decreased amplitude with repetition. No rigidity was noted, and really maybe other than slight stoop posture, the gait was unremarkable. What we did notice is this left ankle dystonic inversion and plantar extension that was accentuated when distracted or performing other activities. So this is the video of the patient. As you can see, she's we told her to just rest, don't make any movements, and you see the left foot with that irregular tremor, and definitely there is this inversion of the left foot, as well as a slight plantar flexion. It was strange because, as you may notice with her right foot, she intermittently tries to move it to touch the other one, and we asked what is that about, and she's like, well, it gives me a little bit of relief on the tension on the foot. So we didn't classify this other than maybe a stereotypy or just kind of an alleviating thing that she does, but definitely the concentration is on the left foot that has that inversion. We're having her there just hold the foot, and slightly so, we start noticing that irregular tremor there with the increased inversion. Again, this had been there intermittently, but definitely over the past few months, more and more present. So this, let's take it by parts, and let's talk about the initial or main issue for this person, which is the leg discomfort. So based on the phenomenology of observing the movement, we can probably agree that this is dystonia, and it's a focal dystonia of the left foot. So let's talk a little bit about focal leg dystonia. It's rare compared to other focal types of dystonia in adults. The main type of dystonia that we see in adults is it's a hand type of dystonia. However, for children, specifically with certain types of genetically confirmed dystonia, especially DYT1, DYT5, a leg dystonia could be the initial feature. However, on adults, the left foot dystonia, it's not that common. And if present, the etiology is usually secondary to mechanical issues, trauma, repetitive motions, such as in some athletes. Could be a presenting manifestation of Parkinson's disease, and maybe we are biased because in a movement disorder clinic, that's what most likely we tend to be, but definitely the cause of a leg foot dystonia is usually associated with a Parkinsonian syndrome. In this type of situations, this foot dystonia is usually triggered by movement or specific positions, exactly the way that this patient mentioned, that when she is driving and pressing on the gas pedal, that's when she feels that the foot is turning inwards. And then if we get to do the Levodopa trial, of course, then we would see, or we would expect that the dystonia would improve as we titrate up or add Levodopa to this to the treatment. So there are other identifiable or the different identifiable causes of foot dystonia. Again, Parkinson's disease, immune-mediated stiff limb syndrome. So some patients with either stiff person syndrome or kind of more focalized or segmental forms of it, they could present with a foot dystonia or foot inversion dystonia as initial presentation, but definitely the post-traumatic dystonias are those that that we consider. So it's usually the most common. It tends to be fixed as opposed to the leg dystonia from Parkinson's, where it's more dynamic and depending on position and movement. A traumatic type of leg dystonia, it's more fixed to that specific position and really doesn't have much of a dynamic feature. It usually tends to be painful or associated with certain levels of soreness, and it's definitely one of the most difficult to treat. Besides that, we always have to consider in the differential, depending on what the presentation would be and if there are any red flags present, a psychogenic nature of the dystonia. So how do we make diagnosis of dystonia? It's basically recognizing the manifestation. So phenomenology is the most important thing. hopefully by observing the case in different scenarios at rest, triggering with specific movements, with distraction, we'll be able to clearly define that we are looking at a agonist-antagonist simultaneous contraction of a group of muscles that is causing an abnormal posture around that joint, in this case, the foot. And it's really dependent on examinations experience. So there might be some dystonias that have some additional components, especially if they come with a lot of dystonic tremor, that it might be difficult to recognize. So we have to acknowledge that. It's also, we have to remember that in order to get to the right treatment, we have to be good at recognizing what are the muscles that are involved, because since the gold standard for treatment of dystonia is botulinum toxic injections, we gotta identify what the right muscles are, basically what the dystonic muscles are there. So we don't have any current diagnostic tools that allow an objective or definitive diagnosis of dystonia. Still remains the phenomenology, the clinical observation of the movement. However, in certain situations, is more used as to exclude secondary causes, especially in a situation like this, for example, where a patient feels that the movements began after this specific tendon repair. Other patients may explain or say that after maybe a vascular-like event. So anyhow, there are some imaging modalities that we could utilize from time to time. So basically, MRI of the brain or PET studies that can help us rule out some structural focal lesions at the level of the brain, basically expected to be around the thalamus or basal ganglia. So what about EMG in the diagnosing of dystonia? This is somehow a little bit of a controversial. We don't use it systematically, just because the data that exists there to really classify or label a movement as dystonia is not quite uniform. Nevertheless, for people that do, if we are lucky enough to evaluate EMG on a patient with dystonia that we are very certain of the diagnosis, there are some features that we can pick up from an EMG analysis. So basically, it's a time domain area that we are exploring, and basically we try to identify the co-contraction of antagonist muscles. So, for example, if we're evaluating for cervical dystonia in the neck, maybe you would choose an splenius and a sternocleidomastoid, because that would be an agonist-antagonist action. If you are evaluating, for example, the foot, you would take the tibialis anterior and the gastroc. That would be agonist-antagonist. Maybe in the hand, the extensor digitorum longus or flexor digitorum longus on the foot, sorry. And then you identify a continuous background of EMG activity with these multiphasic or oscillatory activation patterns. And basically is this rhythmic, low pitch firing that resembles frogs croaking. There is an antiphasic activity due to the overflow of the electric activity. So basically muscles around it, although not necessarily dystonic, can also have this overflow activity. There are some studies that kind of have tried to see what, as far as EMG characteristics, in the frequency domain, and they pretty much established that maybe a decreased median power frequency may allow to identify those dystonic muscles. Therefore, we don't have to rely so much on antagonist activity, but this is yet to be, has not fully been developed. So in general, we do not order an EMG to make the diagnosis of dystonia. However, in a general movement disorder clinic, we do see patients that have already had that, and we will have the records, and we're able to pick up and look for some of these features. If they actually needled the dystonic muscle, we might find this. But again, it's not a common practice ordering an EMG to make the diagnosis. It can be some aid in the situation. The patient that I was talking to you about, she did come with an EMG, and it was mainly talking about some denervation on that area with some background activity in the EMG, which, if I remember correctly, when they mentioned that tibialis posterior, they mentioned that muscle was mostly having some background activity. So this is the MRI that the patient had. It was unremarkable. We were specifically looking at the basal ganglia, making sure that there is no mass, abnormalities in the intensity of those areas, and it was pretty unremarkable. So our differential diagnosis, based on the common etiology, the initial presentation, so we have a focal limb dystonia. However, there is more than that on this patient. As I mentioned, she did have a little bit of bradykinesia on the left side. She did mention having difficulties standing from sitting position, and there was this anosmia for several years. So early tremor predominant Parkinson's disease was the pretty much overall diagnosis that we were seeking, and we did order a DAT scan, and that scan is present here on the bottom. So if you see there on the right striatum, there is decreased uptake of the tracer in comparison to the right side. So the examination, again, showing the Parkinsonism plus the initial manifestation of leg dystonia with this abnormal DAT scan, was for us suggestive that this patient has Parkinson's. What we did is we discussed about the options. Patient was given the option of trying the Levodopa trial, or if not, do botulinum toxic injections, given that upon further discussion, it seems like really she's limited as far as playing with her grandchildren. Wasn't the case 6 months ago, and she implies that maybe she's becoming slower. We decided to do levodopa, and with that, we titrated up to 1 tablet 3 times a day, and there was significant improvement of that left foot dystonia to the point that on subsequent evaluations, we couldn't see it when she was right after taking the medication. So again, this was a case to highlight that leg dystonia sometimes can be the initial presenting symptom of Parkinson's. Sometimes it can really come by itself without any Parkinsonism, and on subsequent evaluations, these subtle findings may be picked up and eventually leads up to the diagnosing. Sometimes cases come to where the Parkinsonism hasn't been picked up. Patients continue complaining with these involuntary movements, the pulling of the leg, and how many times we've seen patients that ended up having unnecessary orthopedic procedures. I had one time one patient that was about to have a tendon release. We luckily saw the patient right before the surgery was planned, and we did the Levodopa trial, and that did completely resolve the leg dystonia. So we have to be aware, and again, in adults, the most likely cause of that leg dystonia, if there is no history of trauma, think about Parkinson's, and if not, monitor for it. All right, so moving forward, before I go to the next case, I just wanted to do a quick review on where are things as far as Parkinsonian syndromes and how we divide them, and we like going more to the histopathological level to differentiate all these Parkinsonian syndromes, because it makes it easier to group them and try to get to the new nomenclatures of most of these conditions. So when we talk about Parkinsonian syndromes, we talk about the cardinal signs that are present. In order to color Parkinsonism, bradykinesia and tremor at rest have to be present, plus any of the other cardinal signs. It is part of our evaluation when we see these patients to first and foremost try to exclude the secondary forms or secondary causes for Parkinsonism, and the list is long. I've mentioned here in the slide just the main groups. So we have infectious, drugs, vascular, trauma, structural, and other, which include metabolic, paraneoplastic, and always psychogenic. So once we've had a good idea based on our very in-depth history taking of red flags, our examination, maybe some ancillary testing, that usually allows us to exclude some of these secondary forms, and then we're left with what we may think it's a neurodegenerative type type of Parkinsonism, and that's what ends up being in a movement disorder clinic the most likely cause of the Parkinsonism, a degenerative condition. So the most common is Parkinson's disease, and from there it's very rare to really get to the point of finding a genetic confirmation of the most common causes of Parkinson's, whether it's LRRK2 mutation or GBA mutation. That may explain less than 10% of the cases. The most common cause is idiopathic, where we really cannot find the root cause. But we also have to be very suspicious, and part of the evaluation is always looking for those red flags that would allow us to exclude or include these typical Parkinsonian syndromes, or the Parkinson's plus syndrome, so dementia of Lewy body, the multiple system atrophy, progressive supranuclear palsy, and corticobasal degeneration. So you can see these in the picture, that we basically divide them in synucleinopathies and tauopathies. Both are amyloid depositions that happen in specific areas or cells in the brain, and we can divide them by synucleinopathies, where we have the multiple system atrophy and all the Lewy body disease group or category, where includes Parkinson's disease, Lewy body dementia, and then we have the other type of amyloid deposition, which are the tauopathies, mainly the progressive supranuclear palsy and corticobasal degeneration. I don't want to go in details, but in all those groups, we have specific subtypes that really is not the point of my talk. I just wanted to make sure that we identify this difference of the different neurodegenerative causes of Parkinsonism. So let's talk about a Parkinsonian case then. For my second case, this is a case of a bilateral hand action tremor. And this was a 56-year-old right-handed male with more than 2 decades of this upper extremity action tremor. The tremor was stable and minimally bothersome, really not interfering much with anything the patient did. However, over the past 5 years, it began interfering with some of the fine motor activities. At that point, he also began noticing a head tremor, more of a horizontal no-no type, and it became increasingly bothersome. On initial evaluation, when the patient came, besides the head and the upper extremity action tremor, he was noticed to have a very, very slight and sporadic left hand resting tremor, with a little bit of bradykinesia and just slight rigidity on the left upper extremity. So at that time, when we evaluated the patient, definitely had features of action tremor, symmetric for many years. So essential tremor was our main diagnosis. However, the fact that there were some red flags and additional findings, such as this resting tremor, a little bit of bradykinesia, we gave the diagnosis of ET plus Parkinsonism. So at that point, we began treatment for tremor as we would normally do. We tried titrating up medications, propranolol, primidone, and he actually didn't get much benefit until both were being used, and we kind of had titrated to pretty decent high levels. Somnolence was the limiting factor of continuing the titration, and along this, he got moderate control of the tremor initially, at least, but also noticing a little bit of balance and mobility issues as the years went by. Before considering, so we had this patient where mobility was becoming a little bit more of an issue. It was being clear on our subsequent evaluations of the Parkinsonian signs, or that maybe the bradykinesia and the rigidity had become more noticeable. So we order a DAT scan, and the main reason at this point why we did it is because patient really did not want to add more medications and wasn't that excited about trying Parkinson's medication if we were not certain about this being Parkinson's, and also the somnolence. He was really afraid of adding more medications. So we said, okay, let's have a little bit more of an objective evidence on it, and then probably would make us help us make the decision. So we did it, and this was the DAT scan that the patient had. As you can see on this DAT scan on the right side, there is almost absence of the uptake of the tracer in the right striatum, and again, you know, her symptoms of the patient were on the left side. So with this, we ended up giving the diagnosis of essential tremor and Parkinson's on this individual. So let's talk a little bit about the use of molecular imaging in Parkinson's and how often and what does it mean. So imaging with PET or SPECT are powerful methods of detecting in vivo changes in the brain at the molecular level, especially here in the dopamine system. PET and SPECT imaging of the presynaptic dopaminergic function has shown marked reductions in certain transporters. So the transporters that have been studied are the vesicular monoamine transporter type 2, VMAT2, the dopamine transporter or DAT, and then a type of the carboxylase that is used. The one that we use and is approved in the United States is the DAT, the dopamine transporter. And you can see what we look for in a DAT scan. We look at the striatum, we look at the caudate, and we look at the putamen. We usually talk about the head and the tail. When we observe the actual SPECT, we are supposed to find this comma-shaped structure bilaterally, where again the head is the caudate and the tail is the putamen. There's various levels and degrees of abnormalities. For example, in this patient, almost the entire striatum, head and tail, are absent. Maybe there is just a little bit of residue of part of the head. Maybe on the contralateral side, it's also not normal. The tail is definitely missing a part. So I would say that this is an abnormal DAT scan bilaterally, but most definitely with severe decrement of the or absence of the uptake on the right side. So what do we how do we use that scan? So basically, the signal loss is asymmetric for the most part, and it can be more profound or starting first with the tail, the putamen, and then advancing to the caudate. There are several again techniques and tracers that have been used, but here in the United States, the only one that is commercially available is a DAT scan, and that's the one that we use it commercially, clinically. All DAT scan studies have demonstrated high sensitivity, around 87 to 98%, and a specificity around 80 to 100% in differentiating Parkinson's disease from non-degenerative forms of Parkinsonism. So again, this high sensitivity and specificity is to differentiate from non-degenerative conditions such as essential tremor, vascular Parkinsonism, drug-induced Parkinsonism, dystonic tremor, and psychogenic. So those would be the cases where we would normally order a DAT scan. We have to understand that that scan does not allow us to differentiate between all the subtypes of neurodegenerative Parkinsonism. Basically, dementia of Lewy body, Parkinson's disease, progressive supranuclear palsy, multiple system atrophy, and corticobasal degeneration. They all have a decreased uptake, and really there are no patterns that make that help us differentiate. So therefore, utilizing that scan to have a confirmatory diagnosis of Parkinson's disease is not correct, and that doesn't happen. The only way that we can finally get to the diagnosis of Parkinson's disease would be, yes, we do have the abnormal DAT scan, but clinically everything fits. Really, when we hear or we say that a patient was diagnosed with Parkinson's based on the DAT scan, it's not necessarily accurate. So one of the things in the works as far as improving the ability of recognizing patterns based on these molecular imaging is that they are studying different tracers and now also postsynaptic type of systems, because again, that scan is we're evaluating the presynaptic neuron, and that has commonalities where all these neurodegenerative conditions are abnormal. However, with using postsynaptic studies that use transporters of the postsynaptic system, we might be able to pick up and make more difference in basically between Parkinson's disease and the atypical Parkinsonism. Nevertheless, we don't have anything in that nature that is clinically available. Going into the molecular still diagnosis, and just as an FYI, what else is it that we use to help in certain situations with the diagnosing of or making difference in all these Parkinsonian syndromes? We use the iodine methiodobenzyl guanidine or MIB-G SPECT scintigraphy, which is a study that helps us differentiate Parkinson's disease from the other Parkinson's plus syndromes. So basically, in most of these conditions, there is impairment of the sympathetic nervous system, especially at the level of the ganglionic myocardial neurons. And we've learned to identify that and help us to make the difference between Parkinson's disease and Lewy body dementia for that means, and differentiate that from the Parkinson's plus syndromes and also Alzheimer's. So the expectation would be, or what you would expect, is that in people with Parkinson's disease and Lewy body dementia, the MIB-G scintigraphy is abnormal, and there is a significantly decreased uptake of the tracer, as we can see here, where the myocardium should be, you don't see any tracer activity, as opposed to patients with multiple system atrophy, PSP, or corticobasal degeneration, where the uptake is normal to just slightly decrease. So this is a situation where that difference, if present in the right clinical scenario, may be helpful. Nevertheless, and the reason that this is not used all the time is because their sensitivity and specificity is moderate. The other testing that we use kind of more in specific cases when really it's very important for us to make the difference of which type of atypical Parkinsonian syndrome we're talking about is the F-fluorodeoxyglucose test, or FDG. And this is a type of PET testing that gives us a specific patterns in the brain as far as the activity of that brain area. So there are specific patterns that we can expect in the different types of Parkinsonian syndrome. So here's an example of a patient with Parkinson's disease where the basal ganglia shows increased metabolic activity. And there is concomitantly decreased activity in premotor and the pre-supplementary motor and posterior parietal cortices. So this would be the expected pattern in Parkinson's. In patients with multiple system atrophy, there is a decreased metabolism or hypometabolism of the putamen, or basically the striatum, also at the level of the pons and in the cerebellum. And in patients with progressive supranuclear palsy, there is a hypometabolism of the frontal cortex, as we can see here, the thalamus, very much absent, and the midbrain. So these type of patterns are things that normally we look for in situations where for us it's important to differentiate one versus the other. In general practice, we don't use them that often, but they're there. They have specific patterns that are recognizable, and under the right situation or scenario, they are helpful. So this is the patient. What happened with him? So we started the levodopa with noticeable improvement of the left-sided dexterity, and overall mobility and balance improved. He tolerated the dopaminergics well, except for some somnolence that was still there, and actually limited our ability of increasing more. Nevertheless, patient was satisfied with the control of mobility. Tremor became, however, the action tremor became more bothersome and severe, especially the head tremor, the hand tremor, to the point that he was unable to write or do anything, any type of fine motor activities. So he was considered a good candidate for deep brain stimulation because medications pretty much we had maxed out. There was the limiting factor with the somnolence. And the discussion with this patient was, he has ET, he has Parkinson's, what target do we use? In his specific situation, the tremor was the most bothersome symptom, and the Parkinsonism had pretty much stayed stable. We had not titrated up the levodopa from the 1 tablet 3 times a day, and that was really doing well. So we decided that VIM target, so thalamic stimulation, was the best for this patient, and that's what we did. He had great response to the thalamic stimulation without any side effects. Eventually, we were able to discontinue the primidone and the propranolol, and he was just on the levodopa small dose and did really well. So this is the patient after he's gotten DBS, but we brought him just for having a comparison of how things are. His DBS is turned off right now, and we are assessing his action tremor. You guys notice some level of hand tremor there. Head tremor, it's more of at this point, a yes type of tremor, although originally he had a no tremor. We see a postural tremor, moderate in severity, especially with the wind beating. It becomes more large amplitude. And his voice becomes very tremulous as well. On the kinetic assessment, he has difficulties reaching target proximally and distally. And we're going to see him here try to attempt to write something. He struggles tremendously, even holding the pen and bringing the pen to it where he feels comfortable to start writing. Has this trick where he puts the finger to kind of stabilize, but even with that, is very difficult to produce a legible handwriting. And then we're going to have him try to do the Archimedes spirals. Still, even difficult to put the pen down to start making any drawing there. Now, this is with the DBS on. Is it playing? So head tremor, very well controlled. Wouldn't even say that he has tremor. And tremor absent. One of the things we don't expect head tremor to get this very good level of control with deep brain stimulation. We do DBS for head tremor when it's intractable, but we have our specific discussion with patients to what level that might help. But in this case, he really gets complete resolution of the head tremor. And as you can see, his kinetic tremor here is ups and slight, and here writing, he is able to actually write something and be legible. And when drawing the spiral, he's able to put the pen down and do a spiral. All right, so this case was to highlight the fact that essential tremor and Parkinson's disease do happen together. Not because having one gives you necessarily more risk to develop the other. And also we have to remember that essential tremor, there is a type or such thing as essential tremor plus, where you can have characteristics of action tremor plus some features of Parkinsonism. All right, so let's move on to the next case. This is a 62-year-old right-handed male with 5-year history of gait difficulties followed by balance instability, decreased speech output, and impaired mobility. The onset of sporadic falls and occasional freezing of gait came around that time, and he was seen by a local neurologist who started levodopa without any noticeable benefit. He did not increase the dose more than a couple times per day because patients said it didn't work and it made him sleepy, so he pretty much aborted that trial there and wasn't completed. And definitely over the past 6 months, needing more help with his walking and using a cane and more difficulties with performance in some of his daily activities. Another feature on review of systems was that he had been noticing some progressive problems retrieving words, or some word substitution, frequent pausing when talking, and longer periods of being silent. Short-term memory and concentration also somehow of a problem for the past couple years. Some constipation, some mild urinary urgency. No tremor noted, no mention of dream enactment, no anosmia, and no hallucinations or paranoia. So family history for the patient was not relevant. He was a retired builder, married, grandchildren. No pre-evaluation testing at the time that he came for the first time to the clinic. And then this was his original evaluation. So I'm having him count backwards from 10, and automatically his eyes shut down and they stay closed, and he's trying to open them, and it's difficult for him. And he had mentioned that also, that not necessarily because he was bothered by it, is because I noticed and I asked, and he mentioned, yes, I close my eyes and it's difficult to open them. So here on the evaluation of the extracular movement, the pursuit is very slow and limited, especially in the vertical directions. You can see that he, beyond the midline, he has difficulties going higher, and also there is some limitation of full downward gaze. Laterally, he's able to follow, maybe with a little bit of a saccadic pursuit. And when we tested for saccades, they were definitely hypometric. The optokinetics on this patient were abnormal. Oh, and the convergence, he has impaired convergence. He is not able to bring eyes inwards as the object is getting close. And on the optokinetics, he pretty much didn't have, he had just very minimal movements with the strip going horizontally. You can see there maybe a little bit, so I would say moderately to severely impaired. And on the vertical, really no movement, so absent vertical optokinetics. So besides those very noticeable and obvious eye findings, patient also had bradykinesia, mild to moderate, very symmetric in upper and lower extremities. Same thing with rigidity, kind of mild, but definitely when trying to assess for rigidity in the neck, in the trunk, that was more obvious. Some stoop posture when walking, lack of arm swing, and some freezing when walking, and definitely there was retropulsion when pulling the patient backwards. So our differential diagnosis in this patient was an atypical form of Parkinsonism. On examination, we have typical findings of Parkinsonism there, but the extraocular movement abnormalities is very, very notorious, and because of that, we consider progressive supranuclear palsy. Patient did have some vascular risk factors, so a vascular Parkinsonism could be, although necessarily I wouldn't expect that level of eye impairment. Normal pressure hydrocephalus, for the fact that there's Parkinsonism, definitely gait abnormalities that are progressive, maybe some, he did mention some urinary incontinence and retention issues, but again, the extraocular movement abnormality, I wouldn't expect to be that severe in that case. So our workup included a cognitive decline workup, which was really unremarkable, an MRI of the brain, which is there on top, and a neuropsychological testing to begin with. So the MRI of the brain did show some of the characteristic patterns that we would expect in patients with progressive supranuclear palsy. On the sagittal views, there is a decreased anteroposterior diameter of the midbrain with the hummingbird sign, where the midbrain shows this concave indentation, and I'm going to show a few more videos specifying on this. And on the axial, we say the morning glory sign with the atrophy of the anterior posterior diameter of the midbrain, and just this to show that there is some level of cortical atrophy. The neuropsychological testing demonstrated some parietal and frontal dysfunction with mild fluent aphasia with executive dysfunction. Therefore, the diagnosis at that point was multi-domain mild neurocognitive impairment. And again, this type of frontal parietal dysfunction are the type of cognitive abnormalities that would be expected in patients with progressive supranuclear palsy. So, progressive supranuclear palsy is one of those, belongs to one of the tauopathies, along with cortical basal degeneration and Alzheimer's disease. There is a specific criteria that we utilize to, with very great levels of sensitivity and specificity, to make the clinical diagnosis of progressive supranuclear palsy. And it has four main categories that we use. The ocular motor dysfunction, which is kind of the most important, the one that usually draw us towards thinking about that is the diagnosis, the postural instability, akinesia, and cognitive dysfunction. So in all of these categories, we have certain levels of certainty, going from lower certainty to high level of certainty. And depending, for example, if we consider the oculomotor dysfunction, in this case, if there is just frequent macro square wave jerks and maybe eyelid opening apraxia, that is kind of a lower certainty type of feature. Then if we find slow velocity in the vertical saccades, that increases a little bit more to a kind of more definite certainty or higher certainty when we have vertical supranuclear gaze palsy. So for all those different categories, we have certain degrees that allows us to make the clinical diagnosis of PSP more at the level of probable, possible, and or suggestive. So characteristics that we use in part of the Movement Disorder Society PSP criteria is that the onset or the nature has to be sporadic. Somebody age 40 or above at onset, and it has to have a gradual progression. So those are kind of the inclusionary criteria. And the exclusionary criteria is that if we have any findings that suggest any other conditions, and from there, based on this four categories of level of certainty, we can make our clinical diagnosis. The other thing that keeps evolving of progressive supranuclear palsy and is very important for us is that we have different subtypes, and understanding or knowing the existence of these subtypes helps us with the differential diagnosis, because the most classical type of subtype of PSP is the Richardson's syndrome PSP type. And that's the classic one, the one that we know that has the very notorious extraocular movement abnormalities and has very early onset of postural instability and falls. However, there's been other types identified, and the one that can really resemble Parkinson's disease, at least for the first few years, is the Psp Parkinsonism type. And this one has a very clinical phenotype to Parkinson's disease. Maybe those are the type of patients that you think they have Parkinson's, but maybe they're not reacting as you would expect to the medication. Maybe it's taking longer, higher doses. They never had the typical resting tremor, maybe having a little bit of balance, gait issues from the get-go. But then along, even from the beginning, you notice, maybe I'm seeing a little bit of vertical gaze abnormalities. Maybe the optokinetic testing is a little bit abnormal. So recognizing this really allows us to have that in our differential and not jump to conclusions, especially if we want to define a patient with Parkinson's disease, even if we are trying to consider this patient for advanced treatment. Maybe we plan on doing deep brain stimulation. We would hate to put a patient who has a very slow progressing Psp Parkinsonism type. And as you guys can see there in the table, there are other types that are categorized depending on the main features. There's a Psp that only has ocular motor abnormalities, another one that has just postural instability. There are the ones that have cognitive abnormalities, such as the behavioral variance, the corticobasal syndrome. And from this, all the phenotypes have a mean disease duration of about 8.7 years. But the Psp Richardson's type is the fastest in evolving and deteriorating with a mean disease duration of 7.3. The Psp type Parkinsonism and the primary gait abnormality with freezing, those have a longer disease duration of around 12 years. And again, highlighting the importance of always having into consideration for the patients that have atypical features that they may be one of those variants that are very slow in progressing for Bsb. Clinical features, again, as I mentioned, we base ourselves basically on the ocular motor dysfunction, postural instability, bradykinesia, and cognitive dysfunction. Patients with Bsb are those that when they walk into our room, just by looking at their faces for a lot of time, we can really be certain that the diagnosis is there because they have these very specific faces. We call it Procerus sign. They look like they're mad, like they're worried, and basically the contraction of all this Procerus corrugator frontalis muscles here. So let me show you a few cases of Psp that I have seen in clinic and really highlighting or pointing towards the eye movement abnormalities. This patient does have Procerus sign. As you can see, the Procerus, the frontalis contraction, and with a stimulation, there's even more contraction and raising of the eyebrows as I'm trying the patient to track. Has a slow movements, a little bit of a saccadic pursuit, and some limitation of the vertical gaze, especially not fully looking all the way up. Convergence is also limited in this case. And I think I'm doing right now the optokinetics out here. And no movement really when doing the strip as far as the optokinetic reflex. So absent horizontally and absent vertically. There's another patient. Playing. I think it's going. Is it? Yeah. So this is a patient. So the patient on the left had this for at least going on 5 years. The patient on the right was more of a recent onset within the last year and a half. So patient has Parkinsonism, pretty much symmetric on both sides. And then upon eye examination, again, has this limitation of extracular movements. This patient has marked limitation of downward gaze. And when we study PSP, one of the most initial signs that we can pick up in patients who eventually are going to develop PSP is that limitation of downward gaze, so much so that we ask patients, how does it go when you go down the stairs? And if they're telling you that, oh, it's for some reason, it's only difficult going down the stairs, that's kind of a sign that you should remember, because one of the earlier signs of PSP is usually limitation of downward gaze. And this patient, again, limitation of the convergence or absence. And you can see also the procerus sign there, some procerus contraction, hyperactivation of the frontalis muscle. It's slightly asymmetric, maybe more on the left side with the raising of the eyebrow. So right now we're doing the drum to test for the optokinetics. You guys don't see any back and forth that you would expect with the horizontal or the vertical. So again, pretty clear eye movement abnormalities. All right. Okay, so I have just a couple more videos. Let's see if it plays automatically. I'm getting to the end of my talk, and I want to leave some time for questions. So if I have issues playing this, I think I'm gonna just end up here. So, all right. So this is the end of my presentation. We're getting to the end, and at this point, if there are any questions, I'll be happy to take them.
Dr. Castaneda, thank you.
Thank you. I'm sorry?
Dr. Castaneda, thank you for this timely review. I really enjoyed the EMG in Dystonias, the molecular imaging in Parkinsonism, and this update on the diagnostic criteria of PSP. We have a question here regarding the use of EMGs in differentiating psychogenic dystonias from other types of dystonia.
Thank you, Dr. Toledo. So again, we go to the situation where there is no unification of the criteria for calling dystonia. However, in certain situations, if we are able to really get to the muscle that we are thinking is the culprit of the movement, and if we happen to have antagonist coactivation, then probably that would be something that would be suggested. Because, you know, if I have the psychogenic movement and I am voluntarily or subconsciously activating that muscle, still the EMG is going to pick some hyperactivation patterns, and we could still not really be able to pick up the difference. However, knowing that in dystonia, there's usually an agonist and antagonist contraction, then we probably, in a psychogenic case, may not be able to find that antagonist co-contraction of muscles, and that somehow may be able to help differentiate. But again, when I am evaluating a patient for psychogenic dystonia, EMG is not something that I use as a method of differentiating, because things can get very, very, very murky. Because the other scenario is that, what if, because again, since there is no consensus, that EMG comes as, yes, there is dystonia, but me, clinically, I still don't feel that it is. It will be one more tool that the patient is going to use for that confusing situation that it happens with all these psychogenic patients and shopping physician to physician. So I would stay away from using, for psychogenic reasons, EMG.
Thank you. Thank you. That really makes it clear. If you have any questions and you are virtual, please submit the questions in the box. Or if you're in the audience, you can use any of the mics. I don't have any additional questions here in the box, and I cannot see the audience. So, Dr. Castaneda.
All right, it's been a pleasure. Thank you very much.
Thank you, sir. Thank you.